Hi students, so for this presentation we're going to talk about macular degeneration and hearing loss. So macular degeneration is an age-related vision loss. It is the most common cause of irreversible central vision loss in people over the age of 60. Now there are two different types of macular degeneration. You can have exudative or non-exudative, also known as wet and dry. Dry macular degeneration is the most common. It's a gradual blockage of the retinal capillary arteries, and it causes ischemia and necrosis. So the capillaries in our eyes are slowly being blocked, and we have tissue damage because we can't get blood flow. And that one is the most common. Wet macular degeneration is the most severe. And this is where we have new growth of blood vessels that form, and they're really thin and they easily leak blood, and that can lead to central vision loss with the blood leaking in the eye. Risk factors for getting macular degeneration is age, of course. It happens over time. Genetics, people who have family history of those with macular degeneration are at higher risk for getting it themselves. Smoking, hypertension, especially with that wet macular degeneration, higher the blood pressure, and with those thin little blood vessels, you're going to have more leaking of blood, and the female gender. So signs and symptoms of macular degeneration is that lack of depth perception, blurred vision, the loss of the central vision, and blindness, and that's going to be in time. They will actually go ahead and diagnose this with the ophthalmoscopy, and then they'll be able to tell if they're going to have a progression of the macular degeneration. So there are a couple different treatments in nursing care, but there is no cure to this. They can do laser therapy to help seal those leaking blood vessels if it is that exudative macular degeneration. And then there is medications that we can put the patient on to help slow the disease. These medications are going to be used to stop formation of new blood vessels, but not cure it. Here we have a list of a couple different types that you can see, a couple different eye drops. Big thing to know for nursing care is that side effects can include blurred vision, eye irritation, eye pain, and photosensitivity. And if there are injections, then they are given generally from 4 to 6 week intervals, depending on how the patient responds to it. Another part of our nursing care is diet changes. We will encourage the patient to have supplements of vitamin C, E, beta carotene, and zinc. That will help kind of decrease the progression of the macular degeneration. Also, we can have them increase lutein supplements in their diet, and that may also help some patients. And we can teach the patients to eat foods that are dark and green leafy vegetables, such as kale and spinach, and fatty fish, which is also great for them. And they should be doing this at least twice a week. And then, of course, we got to provide care for a patient with a general vision loss. And that's just things like putting on a nightlight in the hallway so they know where the bathroom is and can find it easily. Making sure that the floor is nice and clean and free of obstructions or things that could trip them. And making sure that you're when you come into the patient's room, you address them at the door so you don't startle them by the time you're at the bedside. Those are some little things we can do for a patient with general vision loss. Education, again, diet change, consuming foods high in antioxidants, carotene, vitamin B12, vitamin E, and lutein. We can provide community organizations and support groups. And we need to educate them that vision loss may be irreversible, but things can be done. So we don't want to give the impression that nothing can be done, like this is an end-all be-all. No, be encouraging that we are going to start them on a treatment plan to help slow this progression. All right, so now let's move into talking about hearing loss. Hearing disorders are a common cause of disability in adults. Age is the strongest predictor of hearing impairment. In the United States, about 25% of those aged between 65 and 74, and 50% of those older than 75 have some sort of hearing loss. There are two different types. We have conductive hearing loss and sensorineural hearing loss. I'm going to quickly talk about conductive hearing loss. So this is going to be the main focus of this module. But conductive hearing loss is a condition in the outer or middle ear that impairs the transmission of sound through the air to the inner ear. So our examples are going to be like impacted cerumen, otitis media with an infusion or fluid buildup, a temporal membrane perforation, otosclerosis, or that narrowing of that external auditory canal. So when we talk about sensorineural hearing loss, this is an impairment of the function of the inner ear of the vestibulocochlear nerve, or the cranial nerve 8. Some examples is genetics. Some people can have hearing loss or at risk for hearing loss simply because of genetics. Noise exposure, aging, Meniere's disease, trauma, and ototoxicity. And that's one thing to pay attention to. If ototoxicity is a side effect of meds, of one of your medications that you're giving, you might want to be careful with a patient who already has some hearing loss. Now, the signs and symptoms are going to vary based on the location of the problem in the ear. Some things that you'll see is that the patient answers questions inappropriately because they don't know what you're asking. They might be straining to hear, and you'll see this by them cupping their hand around their ear or focusing on reading lips. They might have sensitivity to slight increases in noise levels, have feelings of fullness or pain in their ear. The ear might be red and inflamed. When looking in the ear, there might be a bulging tympanic membrane. It could have a fever from infection, tinnitus, or that ringing, vertigo symptoms, which would be dizziness. They could have a nystagmus. It's when you see the eye twitching back and forth, and balance problems. Also, the patient might be very irritable and frustrated if they cannot hear. So we have a couple different ways to diagnose hearing loss. One of the first ones is audiometry. This is non-invasive. The individual will have headphones over their ears, and they will hear tones at different levels and in the right or left ear. Another one is a tympanogram, which measures the mobility of the tympanic membrane and the structures around the middle ear. And a Weber and Rhine test, and this is using tuning forks. You can see that in the picture on the right. It uses air conduction and bone conduction. And then lastly, of course, an otoscope. So some nursing care for our patients with hearing loss. We want to make sure we provide fall precautions because balance might be affected. We want to avoid ototoxic medications. Some examples are Lasix, an antibiotic called gentamicin or erythromycin, our NSAIDs, aspirin, and ibuprofen. Those are some that you want to be careful with our patients who have hearing loss. Make sure they have assistive devices, again, for having good balance. Maintain eye contact with these individuals. That way they know that you are talking to them, as well as they might be trying to read lips. You want to remove background noises, turn down the TV, shut the door in to the hallway. Speak in the better ear. You can definitely ask your patient, can you hear me better on this side or on the other side? And then use that ear to speak into. Use simple sentences, short sentences. Don't yell at them. You might have to change your pitch of voice, but you don't need to get louder. You might need collaborative care. You may need an ASL interpreter if the patient is completely deaf, and provide lots of patient education. So let's talk about our geriatric population for a second. So presbycusis is a hearing loss associated with aging. It could have a loss of peripheral auditory sensitivity. They have a decline in word recognition ability, and there are some psychological and communication issues with presbycusis. These patients can't hear high-pitched noises. So that's when, again, we might want to lower a pitch of voice so it makes it easier for the patient to hear us. This is often caused by prolonged noise exposure. And one other thing to just note with our elderly population is they may not want hearing aids. And there's a couple reasons why. It might be too costly for them. They might not like the appearance of how it looks having a hearing aid. And so there might be some denial that they have hearing loss. And also, as we age, we lose some dexterity in our hands, and these hearing aids and the batteries have such small parts and can be difficult to kind of manipulate. So, just be aware that those are some reasons why some of our elderly don't want hearing aids or might not always wear their hearing aids. So you can provide assistance if they have the hearing aids, getting them put together and in the ear properly. But just note that some might not even have them. So patient education we can provide to patients to prevent hearing loss in the first place is by avoiding continued exposure to noise levels greater than 70 decibels. That's essential in preventing hearing loss later. Wearing good ear protection, especially if they're working in a certain facility that has a lot of high volume noises. We want to monitor audio levels, and we want to avoid injury from cotton tip applicators and other cleaning. So there are some things that we can do to prevent damage to the ear and diminish the hearing loss over time.